Hello again, this is Chow, and this is a video on the basics of taking an ocular history. I think as medical students we don't get taught very much about how to properly take a history when it comes to somebody that comes in with an eye complaint. So the first time that it happens, it's a little bit difficult and you don't really know what kind of questions you should be asking. So hopefully this video will assist you in that and sort of give you an idea of what are some good questions to ask and sort of maybe what sort of things might be going on depending on what the patient tells you. Okay, so chief complaint in HPI. Again, this is pretty much just like any other sort of chief complaint in HPI that you might ask for any other thing, except it'll be about the eye. One of the things to ask is, is it happening just in one eye? If so, which eye versus both eyes? You'll definitely want to ask about onset, severity, duration, what makes it better, what makes it worse, as well as any other treatments or interventions that they've tried. Has this sort of thing ever occurred before? And if so, when? And what happened? How did they fix it? What was the outcome? So again, this should all be pretty familiar to you. It's just like any other sort of chief complaint that you would ask about. The part where it changes a little bit is the review of systems. In ocular review of systems, I like to break down in a couple different categories. And the first one is sort of changes in vision. So these are sort of questions you can ask a person about their vision change. The first is you can ask, have you had any flashers and floaters? A lot of people say they see more floaters than usual or flashes of light that kind of shower across their field of vision. And this can signal a retinal detachment. That's sort of, keywords for retinal detachment in ophthalmology world. Other things you can ask about, so was there a shade or curtain over their vision? This can again also signal retinal detachment, but you also probably learned about something called emerosis fugax, where there's sort of that transient loss of vision in one eye that may come like a shade across the vision. You can ask about distortion or wavy lines. So you can say, does it look like the lines on the road are wavier than usual, or things are looking a little distorted or weird? And this is usually the first sign of something called macular degeneration. You can also ask about glare. Some people might come in complaining that, hey, I notice that when I'm driving at night, oncoming headlights are so bright. And that's often the first sign of kind of a significant cataract developing in the eye. Somebody that comes in with blurry vision, you can ask, is your vision blurrier than usual? And this is usually some sort of corneal pathology, or, if they haven't been to the eye doctor in a while, they might need a new glasses prescription. Scotomas, or areas of your vision that are darker, blocked out, and this is usually a central visual pathway issue. You can refer to my video on the central visual pathways for more information about what different scotomas mean. And you can ask about double vision. There we go, double vision, which is usually misalignment or some kind of eye muscle palsy or motility issue. One thing that's important to ask about when somebody complains of double vision is that whether it happens when both eyes are open or when one eye is closed. So you can ask, does the double vision go away when you close one eye? Because usually if it does go away when you close one eye, that means it's usually a misalignment or palsy motility issue, and this is by far the most common reason for double vision. A monocular double vision, on the other hand, where double vision remains even with one eye closed, is a central issue and is more rare and definitely more difficult to treat. And then last but not least, if somebody complains of sudden painless loss of vision, this sort of is a red flag for what you call retinal artery occlusion, which can lead in permanent vision loss. So flashes, floaters, shades or curtains over your vision, any distortion or wavy lines, glare, blurry vision, scotomas, and double vision. These are all sort of ROS questions that you can ask somebody that comes in with an eye complaint to help you narrow down the reason for their complaint. Okay, a second category of review system questions you can ask about are pain. So photophobia can mean uveitis or meningismus, as associated with meningitis. Um, Uveitis is sort of an inflammation of the anterior structures of the eye that can cause some muscle spasms in the ciliary body that cause pain whenever your pupil is trying to dilate or constrict. You can ask about pain with or without extraocular movements. Does your eye hurt more when you're trying to look around? Usually your classic case of multiple sclerosis is a young white female with some visual changes or loss of vision or blurry vision, and that has pain with extraocular movements. So it's good to be able to pin down whether or not that eye pain is specifically when the eye is moving or when it's just resting. Oops, sorry about that. Okay, and the other thing you can ask about is headache. Have you had any headaches? Typically, loss of vision plus headache in an older individual, you would consider temporal arteritis as a reason. All right, and then do you have any foreign body sensation? Does it feel like something is in your eye? Usually when somebody feels like there's something in there usually is something in there. If not, corneal abrasions can also feel a lot like there's something in your eye. So if somebody is complaining of that, then you might want to take a closer look at the cornea and make sure there's not some kind of abrasion. All right, and then other sort of ROS questions you can ask. Is there discharge? Is there redness? Is there tearing or itchiness? Conjunctivitis can lead to discharge as well as redness. Acute angle closure glaucoma, scleritis, and episcleritis can all lead to eye redness as well. And tearing and itchiness is usually a sign of some sort of allergic process going on. All right, so hopefully that was helpful in so far as showing you all of the different sorts of eye-specific review of systems questions that you might ask of somebody that comes in with a visual complaint. All right, so in ocular history, does the person wear glasses? And if so, are they for reading or for distance? If they're for distance, if they happen to know their prescriptions greater than -6, or I guess more negative than -6, that person's at an increased risk of retinal detachments. So if an individual comes in and says, I've seen flashers and floaters, and you also know that they wear glasses and they have a pretty high prescription, there's a good chance that they might have a retinal detachment. You can also ask if they do wear glasses, when was the last time they had a prescription? If they're coming in with blurry vision complaints and they haven't had their eyes checked and had new glasses prescriptions in 5 years, maybe all they need is a new glasses prescription. And if they wear contacts, big question to always ask of people that wear contacts is, do you sleep in them ever? 1 or 2 nights is okay, but if they make a habit out of sleeping in them, it puts them at increased risk of corneal ulcers and infections and really pretty terrible stuff. So I would, if you get the chance, encourage your patients not to sleep in their contacts, even though the commercials say that they can. All right, and then you always want to ask about personal history of surgeries such as LASIK, strabismus, cataract, any traumas that they might have had to their orbit area or even their head, and if they have any history of glaucoma, macular degeneration, retinal detachments, that sort of thing. As far as family ocular history, all of these things are good to ask about. They kind of increase your chances of getting them if somebody in your family has them. Okay, and then prior medical history of the patient, things to pay attention to: diabetes, hypertension, and rheumatic disease all have ocular manifestations that can lead to blindness, so it's pretty important to know if your patients have these, whether or not they're seeing an eye doctor. In terms of rheumatic disease, ask about Plaquenil use. Plaquenil is a drug that's a disease-modifying agent, but it does have ocular toxicity that is dose-dependent. So if somebody's on Plaquenil for a really long time, you should make sure that they're seeing an eye doctor. Other things, sickle cell, just like in a sickle crisis where you can infarct within your bones or within your lungs, which cause pain, you can actually infarct in the vessels in your eye as well, which can then lead to vision loss and blindness. And also You need to ask about chronic steroid use if you have a patient that for some reason has to be on steroids. Long-term steroid use can lead to early cataract formation in those people. So it's another thing that you want to sort of know about and keep an eye on. All right, and then the last bit of a history is your social history, and mainly smoking is the biggie. Use of smoking cessation, KCK workshop skills. Smoking has definitely been shown to be a risk factor in the development of macular degeneration. So if anything, if people don't care about their lungs or lung cancer, you can tell them that they might go blind if they continue smoking. So there's your chance to do a little bit of lifestyle modification counseling for your patients. All right, so really, I guess that's just the beginning. Thank you again for listening.